So we commissioned a study. The product of that study is the report and over 2 years of work with the researchers here today. I think you'll find that the report provides a comprehensive, in-depth analysis of long-term care programs in California, and it also provides recommendations for our consideration to improve the structure and management of funding long-term care services and supports. I actually predict this will be an excellent resource manual for years to come. And we hope that the report stimulates discussion among the administration, our legislative colleagues, and external stakeholders on how to improve the long-term care system in California. This report is the result of a hugely collaborative effort. We had tremendous support and technical assistance from many state departments, as most particularly Healthcare Services, Social Services, Public Health, the Department of Aging, Office of Statewide Health Planning and Development, Developmental Services, Mental Health, and the Department of Rehabilitation. So I really appreciate all of their assistance throughout the last 2 years. I also want to thank Kate Wilbur and Charlene Harrington, who served as California long-term care experts. They provided technical assistance to the project and the researchers over the last 2 years. I have an advisory committee, the California Community Choices Advisory Committee. There was a finance subcommittee who worked with me over the last few years to develop the project, the scope of work, provide input on it. And I want to thank them, June Simmons, Allison Ruff, Eldon Luce, Deborah Doctor, Bob Sessler, and Ann Guerra. I also want to thank Megan During, the Assistant Secretary for Long-Term Care at Health and Human Services Agency. She was very key in helping me transverse the state departments and find the right people to provide information to Bob and Les. And I also want to thank the many individuals and stakeholders who met with Bob and Les, particularly in the first year, including those who participated in the community forums we held throughout the state. And now it's my pleasure to introduce to you two extraordinary researchers, Bob Mollica and Les Hendrickson. Collectively, they have over 50 years' experience. They are well known nationally for their expertise in Medicaid, state long-term care policy, analysis of data, and long-term care financing. And I think we were very fortunate to have their expertise and knowledge in working on this report. And I think that their experience is reflected in the quality of the analysis and the product that you have today. And it's also, by the way, been an honor to work with you over the last 2 years, so thank you. Okay, I'll turn it over to Bob and Les now.
Well, thank you. I want to reiterate our appreciation for all of the time and work and effort that many people in the state of California, both state agency staff as well as stakeholders, committed to this project. It was much more complicated than we expected when we first heard about this project, and we apologize for the weight of the report, but Carol said we got paid by the pound, so it's longer than it might be. We had several discussions with members of the advisory committee and others about what we were going to focus on, and we, early on in the process, decided to focus on Medi-Cal services, including IHSS, the waiver, home and community-based waivers under Section 1915C, nursing facility services, and adult day health care services. We did not include any of the state-funded programs that the state has, and or any of the Older Americans Act funding. Our focus was primarily on Medi-Cal services. We also found that there were some significant challenges to studying long-term care in the state. Obviously, a lot has changed since we completed the first draft of this study. The data that's in this is primarily collected in 2008. We started in late in 2007. And since we finished the data gathering, a great deal has changed, and the environment today is very different than it was when we were here back in a year ago. So some of the challenges that we know that you face are, and we face as researchers trying to understand your system and make recommendations that would hopefully improve its balance and its choices for people with disabilities. But the fiscal climate is probably the most dominant challenge that you face. The geographic area, it's always interesting to compare states, and you end up concluding that, well, California is unique, and every state, when they, after some point of comparison, they throw up their hands and say, well, we're different because, and that's true. but California is truly different than any other state that I've been involved in. Services are covered by multiple state agencies. Which makes it difficult to get a coherent plan for structuring your services and monitoring and funding them. Except for the DD system, the DDS system, there's generally a lack of a streamlined access, and people end up hearing by word of mouth or by making phone calls about one service but maybe not another. They often might get a referral from their physician and end up in one program without knowing what else is available. We found that to be a problem for making informed choices as well as developing the most cost-effective service plan. And this is exacerbated by the lack of a common database that allows policymakers to track utilization, compare participants who are in nursing homes versus home and community-based services versus IHSS. So the lack of a common database makes managing the system that much more difficult. We talk a lot about balancing long-term care, and at several points people said, well, what is balance? And on many measures, California spends far more money on home and community-based services in terms of percentages and other denominators than other states do. There is no commonly accepted definition of what a balanced system is. It's to some extent it's a system. A system is balanced when it offers consumers on a full array of choices and settings, and it allows services to be where the participant prefers that they be, and they're funded. Then the funding is there when they need the services. In the end, it's defined by each state's policy. I remember some years ago when the state of Vermont, which in terms of comparison to California is a rounding error, the state of Vermont was spending 30% of their funds on home and community-based services and 70% in the nursing home. And they said, well, let's try to reach 38% or 40%. 40% it was. And so they, over time, over several years, they approached 40%, and they said, well, we're making good progress, but we can still make more, so let's change it. And states can keep changing where they are, where they want to go, and what they will define as balance. There are obviously different ways of measuring how balanced your system is. The most common way is to measure the percentage of service, the percentage of funding spent on home and community-based services. Another way to do it is to measure the number of people served in community settings, or the months of service in an institution versus the community, or tracking access and information and access to information about the full array of choices. You could track, compared to prior years, how many people enter the system through a nursing home as their first point of contact compared to how many people their first service and access to the system is in the community. And that would track not only how well your system is performing, but also how extensive people are gaining information about what's available and what their choices may be. As I mentioned, there often states will compare themselves to others, and one of the more common sources of data is the Medi-Cal expenditure data that's reported to the Centers for Medicare and Medicaid Services on Form 64. It's compiled by staff at the Thomson Reuters consulting agency. They've been doing this for almost over 15 years. However, there are some limitations in that data system. It doesn't count it doesn't count any state-funded services, and in some states like California, which pays for adult day health care not as a waived service but as a state plan service. There are 10 or 11 states that do this, much to CMS's dismay. But those expenditures aren't reported separately. So there are other services like targeted case management that aren't reported in the CMS 64 expenditures report. So it does underestimate where a state is in terms of comparing them to other states. Another key issue is defining institutions and community settings. We had discussions with some folks in California that small ICFMRs were really more like group homes and were home-like and really shouldn't be considered an institutional setting. However, that's the way they're licensed. Many people consider assisted living either institutional or home-like apartment community settings, depending on the state's licensing regulations, or if there are more general licensing regulations that don't require apartment settings and other aspects that you might find in a home setting. There might be individual facilities that are more institutional or more community-based than some others. So defining institution and community is a challenge. CMS has indicated that it plans to address this in regulation, both for 1915C waivers coming soon and also in their 1915I state plan HCBS service. There are provisions, and they differ in each of the separate regulations, proposed regulations. So we can expect that CMS may begin to help states define what a community setting is. So having explained the caution about using the CMS 64 data, it is commonly used, and states often look at this to figure out where they are in relation to their peers and where they are in relation to where they want to be. I remember hearing that at least one state was not thrilled but took advantage of being ranked very low because they could take it to state legislators and other policymakers and say, see how poorly we're doing, we need to do better. And then others would argue that they're really doing better than the numbers show. But the data do show that in terms of participants per 1,000, California ranks first in the number of personal care participants, which is IHSS. Because IHSS is so extensive, it may help explain that you're 42nd in the number of waiver participants per 1,000. And when you combine both indicators, you end up in 6th in total participants per 1,000. The figures are similar in per capita spending for all populations, 4th in personal care, which is IHSS, 18th for total HCBS, and 48th for waivers. So the huge IHSS program offsets the lower participation and spending in the waiver programs. Looking at nursing facility spending, you're 41st per capita and 33rd for ICFMR spending. These are the percentages for all populations, 54% compared to 42% on average nationally. Looking just at older adults and individuals with physical disabilities, California spends 52%. This is 2007 data, 52% on home and community-based services compared to 31% nationally. These numbers will change, obviously, if the budget cuts are implemented. They will change a little bit when the 2008 fiscal year data is available anytime soon. And looking at individuals with developmental disabilities, the state spends about at the national average for services to people in community settings through waivers. Some other key findings. As I mentioned earlier, the program responsibility is spread across multiple agencies, and only DDS has what would be called a single entry point system, where one entity is responsible for outreach, for information and assistance, for screening, assessment, determining the level of care, and functional eligibility for the different programs, developing a care plan, authorizing services, and then monitoring and arranging services. We also found that there was no statewide agency strategic plan for long-term care. An agency means the Health and Human Services Agency, not the departments. We did find that DHCS did have a strategic plan, and there were some elements of the strategic plan in other agencies, but in other departments. But overall, if you asked what's the state's plan for long-term care, we didn't find one, and we thought that the state would benefit by making that a priority. We found that because of some of the financial eligibility options that the state elected to implement, that there's some institutional bias where people will go into a nursing home and spend down more readily and become Medicaid eligible, and it was more difficult to do that, and there's an eligibility option recommended that would address that. We also found that when new programs come along, in the absence of a single entry point for older adults and individuals with physical disabilities, that there's no logical building block, so that if a new program is a little bit different than the existing ones, it often tries to create its own infrastructure in order to implement the program. Les, you want to present the next slide?
If you look at the census in developmental centers, you'll see that the state has made substantial progress in lowering the census in state developmental centers. In the private developmental centers, the census has actually increased a little bit. What has happened in the private side is that there's over a 20-year period, there's a much greater reliance on smaller ICFMRs than larger ICFMRs, and we show various pie charts by decade showing the growth in the use of smaller ICFMRs. We have several sections of the paper, both in Appendix G as well as in Section 6, which show comparisons between California and the other large states such as New York, Texas, Pennsylvania, and Florida and the United States, comparisons of the number of beds, number of homes, Medicaid or Medi-Cal census in them. We took a really close look at the AB 1629 methodology, and one of the points we raise out of that is the need to control for low occupancy in thank you, in nursing homes. We also looked at rates of increase in payments made to nursing homes. The rates exceeded general inflation and matched medical inflation.
Yeah, I want to point out that the numbers that are on the slide are different from the ones that are in your handout. They were, when we looked at them, there's an error there. And so the numbers that are on the supply and Medi-Cal census for California and nationally are different. Supply of beds between 2001 and 2008 declined 0.6%. compared to 1.6% nationally, and the Medi-Cal census dropped 0.4% compared to 8.3% nationally.
The question of cost effectiveness is a really difficult one to look at. This is more of an impression rather than a fact, but the impression that we had is that the dialogue is somewhat frozen over this, in that on the one hand you have program folks who wish to expand programs and believe that home and community-based care is cost effectiveness. On the other side you have budget folks who think that any expenditure on anything is an increase in expenditures, and always raise the question of, well, what about the woodwork effect? Won't people come out of the woodwork to take these programs who wouldn't have gone into an institution? And the dialogue appears to be frozen in the sense that these views have just simply existed or coexisted for a very long time. They're very understandable. As a former budget analyst in a Medicaid program, I was certainly taught my first week on the job that the standard answer is no. And if you really get pushed and people want a really long and lengthy and elaborate explanation as to why you're saying no, just say no because we can't afford it. But that dialogue has to be surmounted and overcome. Our impression is that people need to move that dialogue to a different stage of discussion. And So we hit really heavily on the concept of cost effectiveness, and we have, especially in Section 8 of the report, you could see we really work through 4 or 5 key topics. One, we look at we basically ask the question, where are they? If you look at national utilization statistics, a lot of people are not in California nursing homes. And I mean, tens of thousands of them aren't. And so our question is, there's a cost avoidance savings that is occurring, and we attribute this primarily to the impact of the IHSS program and the home and community-based care programs of the state, plus the adult day health care program. We also look at the state's own reports that they make to the federal government. And it's called the CMS 372, and each year the state is obligated to produce a federal report. It vouches that it's accurate under pain of federal disqualification of funds. And if you sum across all of these 372 reports, the cost effectiveness is dramatic. I mean, there's just massive sums of money are being saved. And the usual response to that is, well, not all of those folks would have gone into the institutions, so you're not actually saving all that money. And so we just do an example of what's called a break-even analysis. We take the first waiver. We took the AIDS waiver because it was it was sort of like the first one on the list. And we look at how many people you could serve on the waiver who wouldn't have gone into an institution before you lose the cost effectiveness of that waiver. And we also then do a review of both cost effectiveness literature that's specific to California, as well as national literature on the question of home and community-based care and cost effectiveness. And in general, we argue that that literature, both on California and nationally, shows that home and community-based care programs are in fact cost effective, and that it is really difficult to find examples from states of woodwork effects. The actual woodwork effects. And we really end with a recommendation that the state should study the cost effectiveness of home and community-based care programs. And we noted that when we started the program, Bob and I looked through the available studies on California. We found roughly 6 pages of them. If you actually list them down, this is a well-studied state. A lot of folks have worked on it, and we found like 3 or 4 pages of just studies on financial studies, or just list. You can make a list of 4 pages on just financial studies of California social service programs, and we didn't find a single study that looked at the cost effectiveness of home and community-based care. And so the dialogue then that has existed or not existed, if you will, has not produced the studies to get beyond that point in frozen time. And so we do note that there are available to the state existing consulting contracts that are really kind of open-ended, that really provide for general consulting services around rate setting. And we suggest that under these existing contracts that the state should commission some more intensive look at the cost effectiveness of its home and community-based care programs.
Okay, one of the considerations now, given what's going on in the state of California, is what use can you make of this report? And there's certainly credible concerns that that this is not the time to be implementing new things, and the status quo, is difficult as it is difficult to maintain, and we can't do too much more that's recommended in this report. On the other hand, there are people that see budget crises as opportunities to do things that wouldn't normally be considered when things are much better. So there are 3 ways that people that want to take advantage of an opportunity might use this report. One would be to formulate a transition plan. There'll be a new administration soon, and they need, obviously, when there's ever a change in administration, there's a lot of transition work that's done, and departments describe what the issues are, what the programs are, and what the opportunities or options are for new developments under the succeeding administration. Another possibility would be to look and see what incremental changes might be made that lead the state in a direction that it would want to go. If you don't feel that the state can undertake major expansions or changes of policy, new policy directions, then what are those that will make a difference to consumers that can be done fairly quickly and reasonably inexpensively? And then there's the opportunity to make broad, substantive, really significant changes. And we have recommendations in each of those two areas. There are 28 recommendations in the report. They're organized by two different dimensions. One is about how much time it might take to implement them. There are some general recommendations, some short-term, which could be implemented within 12 months or less, a set of recommendations that might be implemented between a year and 2 years, and then some more complex recommendations that would take longer to implement. And for purposes of this presentation and with input from the advisory committee for the project, we organize them by category. So we'll start with financing, then describe some access and delivery system changes, and then finally the state organization. The general recommendations, in several states you find embedded in statute a philosophy and the legislative intent for all of long-term care services. They are, in California statutes, described for specific programs, and some of them are very well crafted and really set the tone for the way the statute should be implemented, and it gives a lot of direction and guidance to the development of policy and funding priorities. But we didn't find anything that explained or stated the intent of the entire system, all of the mix of programs taken together. And we thought that establishing a philosophy would then lead to developing a strategic plan that would identify which populations would be addressed by the plan, some timetables, some responsibilities, and goals that would be measurable so that you could hold people accountable for carrying out the strategic plan. The financing recommendations, the first one is budget flexibility. And there are a few states that have a unified long-term care budget for older adults and people with disabilities, and it's similar to what might be considered a unified budget for the DDS programs. But in a unified budget for older adults and people with disabilities, it would include nursing facility, IHSS, MSSP, and maybe some other waiver programs. And the report talks about implementing this at the county level, since IHSS is the major program, has a major stake in the operation of the significant component of the state system. You could develop a unified budget at the county level, and in that budget would be included some of those programs that are listed. And the county would be responsible for carrying out the programs that would operate within the budget. And by holding themselves accountable, it means that they would have an incentive to keep people out of nursing homes and actually relocate people from nursing facilities who could move to the community. Now you say, well, that might impose additional financial burdens on the county. The way the budget might be constructed would be to take the existing share of the county IHSS expenditures and convert that to a percentage of all of the spending for whatever services are included in the unified budget. That becomes their maintenance of effort. So if they spend 18.5% of IHSS services, and when you add in all of the other services that might be in the budget, it comes to 5%, then they would be responsible for 5% of the total spending of all of those programs. If they are successful in diverting people from nursing homes or relocating people who can be served in the community, then they might end up spending only 4% of their of the total expenditure. If they spend more if they aren't as effective in diverting people or relocating people, then they might end up spending a greater percentage than they would have in the absence of a budget. unified budget. The other way that a unified budget could be implemented is at the state level, and this would allow people managing the programs to shift resources between programs without legislative approval or perhaps even the governor's budget office approval, depending on utilization and participation trends. It doesn't work quite as well in the absence of one department that's responsible for all of long-term care services. But the state of Ohio is implementing a unified budget, and they do at the current point have programs that are in different agencies. If that model were applied in California, you would have to have a interagency budget allocation process that would be probably very cumbersome to do. So this recommendation, if it were applied at the state level, would probably require implementation of one of the last recommendations in this presentation, which would be to establish one department for long-term care services. Another concept under the financing category would be to reinvest savings in HCBS. In states that have divided responsibility, when Medi-Cal saves money in its nursing home line item, it has other Medi-Cal programs that may be operating at a deficit, and it uses the savings to offset those deficits. Or the Budget Bureau could say, we have a surplus in the nursing home account and we have a deficit in a transportation program, so we're going to shift some of the savings to cover that deficit. What this recommendation would do would be create incentives to keep the savings within the long-term care arena and reinvest them in home and community-based services, so that you continue the cycle that when you offer more home and community-based services, your nursing home census declines or your spending rate of growth declines. And if you continue to reinvest savings in home and community-based services, that trend would continue. It's kind of a self-perpetuating trend. Some of the mechanisms to do this would be to take savings in the nursing home account for people who do move from a nursing home and allow so-called money to follow the person by transferring those funds to the waiver programs that the people end up receiving services from. Another would be to allow the nursing home line item to pay for people who could move to the home and community-based waiver, but there's a waiting list, and it doesn't make sense to have somebody stay in a nursing home if they can be in a waiver, but for lack of money, they end up staying in the nursing home. This is the actual money follows the person concept that the state of Texas piloted started in 2001, and since then, over an 8-year period, they've transferred 20,000 people from nursing facilities to community settings. This is my favorite. A lot of people end up in nursing homes. They lose their home. They can go back, except that they have no place to go back to. And if there are subsidized housing opportunities available, particularly for older adults, there's a waiting list for rental assistance programs and housing choice vouchers. So again, it doesn't make sense to keep paying for somebody in a nursing home if they only had housing, could live in the community. Well, this recommendation would be to take the state share of the match for the nursing home payment and convert that to a housing voucher, so that somebody could qualify for subsidized housing. The state department responsible for it would convert that money and use it to pay the housing landlord or the owner of the housing setting until a housing choice voucher became available. Now, there's a catch there, and that is until they'd have to be on a wait list for a housing choice voucher, and some wait lists are 1 year, 6 months, others are 2 years or longer. Several states have created a state-funded housing voucher, and they call it temporary, and yet when the 2-year period that the voucher's authorized for expires and there's still a waiting list, then they're left with the choice of either continuing it or not, and if they don't continue it, the person may end up back in a nursing home. So it's an opportunity to implement a creative way to increase access to affordable housing, but it does have its cautions too. Nursing facility reimbursement is Lex's forte, so he will take over from here.
About 30 states use a case mix reimbursement system on their staffing side. A case mix is, at least in nursing homes, it's the use of the federal minimum data set to judge the acuity of people, to rank the acuity of people, and then Medicare, for example, pays more for persons who have higher acuities and higher medical conditions. It really makes good sense to have a system like that. It's really the predominant reimbursement theme of the federal government. You could see it in DRGs and home health and in most of their reimbursement policies that they're, especially their new post-acute payment reform that they're considering. They're having said that, our impression is there is absolutely no enthusiasm in the state for implementing this, and that folks are really tired after the AB 1629 struggles, and they reached a reimbursement system and they don't really want to change it. No one wants to go through a major change of it on the staffing component, but it's certainly our recommendation that this would be a better, it would make more sense because you want to pay nursing facilities more if they're taking care of higher acuity people and pay them less if they're taking care of lower acuity folks. The next two points on the slide are really minor points. We went through the AB 1629 methodology. We tried to not discuss topics which had been discussed. For example, staffing results of that methodology system have been well debated in 2 major studies, so we didn't see any need. We weren't going to add any value by talking about staffing consequences of AB 1629. So we did have 2 smaller points, and that's what these last 2 are, that we note in passing, that reimbursement level for property costs seems low. I mean, it's a fair rental value system, but the per diem seem to be low. And the importance of that is that both quality of care and quality of life really need a good property reimbursement to maintain the physical property and the looks and the equipment of the home, of the nursing home. And those are really directly related to quality of life and quality of care. And a reimbursement system that seems to kind of squeeze that a little bit, kind of has quality of care and quality of life implications. Lastly, we just noted that liability insurance is uncapped, and if you look at the per diems, the tail end of it, really, you get some really high per diems on the tail end, and one of those minor housekeeping items you would do if you were supervising nursing home reimbursement would be to just kind of cap that at we understand you may want to try to let nursing homes get all of their liability insurance back, the cost of it, but really some are just a little too high, and it could use a cap on it. Those are really just kind of these latter 2 are more minor points. The next point is not as minor a point. In Section 7 of the report, we talk about occupancy and the need for an occupancy provision. We give an example of what an occupancy provision would look like in Table 71 of the report. But about 20 states, and it's difficult to collect statistics on characteristics of nursing home reimbursement systems across the states, because the federal government doesn't collect any statistics on it. So there is no federal source you could go to, no national study that says, okay, how many states control for low occupancy in their reimbursement systems? So we have a GAO report which has about 20 states do, and that's basically the need to control for occupancy is the following. In a cost-based reimbursement system, you divide your cost by the number of days in order to get the per diem paid to home. As the number of days shrinks in the bottom, as occupancy drops, the per diem increases. And so what states do is they say, we're not going to shrink that number beyond a certain level. And most states pick anywhere from 85 to 90. The GAO study showed an average was 88%. And what that basically says is, we're going to stop that per diem from going up when the occupancy hits that level. And so this is a common practice. We think it should be done. It's a way of really controlling for what's called empty beds, and that's the common way it's usually described. It's, we don't want to pay for empty beds. That's the short policy description of it. We think that the methodology system could be improved or changed by adding that occupancy provision in it. The labor-driven operating allocation is it's a part of the AB 1629 methodology, but it's not a cost reimbursement. So it is not actually a reimbursement of a nursing home cost. Rather, it's an incentive to nursing homes to hire staff rather than subcontract the staff or get like nurses from a temporary agency. And so it is an add-on to the rate as an incentive to the home to hire their own staff rather than use temporary staff. But it's a lot of money. And we did just a quick and dirty calculation in the report, taking all the homes, all the days by the per diem involved, and found it was roughly between 150 and 200 million. In our report, we say 168, but I'm sure the state has other calculations depending on a better measurement. But it is a massive amount of funds, and we think that that's in the AB 1629 methodology, that's really a policy incentive. And we think that the homes could be, that funding could be used to incentivize other things about the operation of homes, to use it for culture change or pay for performance, to use it for better discharge planning. It could be used to help restructure physical plants. If a home has low occupancy, perhaps that funding could be used to help convert a wing into an assisted living wing. I mean, there are ways that's the only, if you will, policy-driven component of the rate, and we think it needs to have a better policy in its allocation, and that should be discussed, other uses that allocation could be made of. Well, I think that's all. We can go to the next one, right? Okay.
In the report, we recommended generally that the state should explore managed long-term care options, and we know that there's been quite a history of legislation that's been submitted to authorize managed long-term care demonstrations. We also recognize that California is the birthplace of one of the more well-known programs on lock now, the PACE program. It's also home of one of the first of 4 social HMO models at SCAN Health Plan that started in 1980. But we've looked at managed long-term care programs around the country and found that there aren't many really exhaustive cost-effectiveness studies that are done on these programs. But in general, the states report that they have high satisfaction. They use multidisciplinary or interdisciplinary care management teams to provide the linkage between both the health needs and the supportive services needs that the members have. They find that they are reducing hospital use, emergency room visits, and have lower overall health costs. Now, some of the fine print of that statement is that while they're lowering costs, they may be lowering costs paid by Medicare if they're dual eligible, because if you spend more to keep somebody in the community and their health is stabilized and doesn't deteriorate, then you're avoiding costs that would be paid by Medicare. But to the extent that Medicaid pays for some of those costs as well, there are savings to be gained from those programs. We also learned recently of a DHCS effort to develop a Section 1115 demonstration program waiver that would add certain populations to a managed care program, and there's not a lot of detail in the long-term care component of it, but it is referenced as being included as part of their plan. Kate Wilbur developed this slide when she was doing some research on managed long-term care programs, and she showed this. The point of this is that there are incredible numbers of silos, and that managed care is one strategy that brings many, but not all of those silos under the auspices of one entity, so that they're responsible for managing transitions across settings and services, and generally coordinating the linkages between those different programs and organizations.
We did look at the quality assurance fee that was it is used with nursing homes, and in a 2-year study, you have a lot of opportunity to be outdated in the course of the study, and so one of our early recommendations was expanding it to include Medicare revenue, which in fact got added after the study was completed. But we also note that there's really there's not a lot of limit on what provider groups you could put a tax on, a provider tax.
We don't use tax.
We use quality assurance fees. The federal regulations don't say you're only limited to certain provider groups, and so the advantage of this funding mechanism is that it is a legitimate way of obtaining increased federal revenue, which can be put back into the industry or into the programs. So it's not simply an income transfer, a transfer of funds from an industry to the state, but the state can in turn put back some of the increased federal revenue back into the industry. To nursing home associations, for example, have lobbied heavily in various states like New Jersey for a provider fee in order to offset the loss of inflation increases that the state was going to not give them in states or in particular years. So there's a long literature on this. We talk about this in Section 9, and also in page 106 we have a reference to the program on page 214. But basically this is a funding compromise that was worked out in about 1991, 1992 between the feds and the states. Massive negotiations. The fee was capped at 6% as a result of these negotiations. It's a valid part of the Medicaid program, and we think that it should be extended and expanded to home and community-based care programs or other provider programs, with the intent that some of the increased federal revenue be sent back to those programs to help them. And that's our reason for including it in the recommendations.
Okay, the next group of recommendations relate to the access and delivery system. And the first one is a recommendation that would streamline access to home and community-based services through using a single entry point for older adults and adults with physical disabilities. The scope of the programs that might be included and the activities that might be included would to be determined, but the possible entities that could be designated or developed as a single entry point could be, they could be regional organizations, counties or groups of counties. They could be Aging and Disability Resource Center sites or the MSSP sites or even an area agency on aging. And the one way to do this is to designate a specific type of entity. Another way is to develop an RFP that identifies the qualifications that an entity who bids on this opportunity would have to have, and the experiences that they would have to demonstrate, and the functions that they would fulfill, and the obligations that they would have as a single entity, single entry point. Another streamlining recommendation would be to expedite the determination of financial eligibility for Medi-Cal. Oftentimes, somebody who's not a Medi-Cal beneficiary but is being discharged from a hospital and is going into a nursing home, the nursing home knows that sooner or later they're going to get paid. If their private pay and Medicaid eligibility is pending, when it's determined, they know that the family or the resident is going to pay for the care that they're receiving. When somebody goes into the community, community providers are less certain whether they will ever get paid under Medi-Cal, or even if they're Medi-Cal eligible. Nursing homes, on the other hand, are very skilled at identifying a person's resources and knowing when or if they would become Medicaid eligible. So co-locating eligibility workers to expedite the process would help divert people from nursing home placements to the community. Diversion, too, is another strategy that we talked about in the report. We use the terms pre-admission screening or options counseling. I like the term options counseling better because it's broader. Pre-admission screening conveys that we're going to do an assessment to determine whether you're eligible to be admitted to a nursing home and whether Medi-Cal will therefore pay. And options counseling takes a perspective that you may qualify to be in a nursing home, but you may want to consider, and that may be your choice, that may be where you are best served. But if you want information about your other options, options counseling would provide that information. Ideally, under a single entry point, they would have responsibility for the programs that the person may be eligible for. So instead of being referred to outside to another entity, to be then again interviewed and assessed and determined eligible, this one person or entity could determine eligibility, do the assessment, and authorize a plan of a service plan. Transition.
We have a lot of a comment on transition. We have a recommendation on it on page 205, which discusses it at length. But a lot of states have transition programs. They Oregon, Washington began them way back in the mid-90s. The feds instituted as part of the Real System Change Grant. CMS sponsored over 30 of them around the turn of the decade, 2000, 2001. And lately there's been this large round called Money Follows the Person of some 30 states, of which California is participating in. But there are states with very extensive ones. Bob mentioned Texas. Pennsylvania helps some 4,000 or 5,000 people a year transition out of nursing facilities. 4,000 or 5,000 in the last 2 years. We think that the transition work is cost effective. there's absolutely no one argues to the contrary, because these are people who are in institutions and you are helping them leave. So it is a budget plausible program, and it's really one of the demonstrable cost-effective programs that the state could expand and strengthen. And a recommendation, it doesn't say how the state should do this, because we think that's really the administrative decision of the state to make, but we want to encourage them to, we think that they could, we interviewed with the Department of Rehabilitation folks and the Department of Aging folks. We were impressed with the work done by the independent living centers in transition. We think that the state could fund staff in AAAs and in ILCs to help take people out of institutions, that funding would be cost effective over the long run, even the short run. By long run, I mean the next 1 or 2 years. And we think it takes several years to build an effective transition program, but we think the current efforts should be expanded, strengthened, centralized, that local efforts like San Francisco City and County is making, that these should be given help and support and bolstered. And so we then really have a strong recommendation about the need to expand and strengthen transition work.
I just want to reiterate or reemphasize one of the points Les made about taking time to build the infrastructure. Of the 30 states that were awarded grants under Money Follows the Person, the states that are transitioning the most participants are those that started their transition programs long before the Money Follows the Person program came along. Texas, Michigan, and New Jersey, and Washington, Pennsylvania are the states that have the most most transitions, and it's due in part to their infrastructure that they had. And states that are building it now under the Money Follows the Person program are having a slower phase-in or a slower rate of transitions because of the infrastructure. And it's not only the capacity to do it, but it's the training, building relationships with nursing homes. This is not an easy program to administer or to implement. And also the quality assurance and monitoring and the backup systems that you need. Some of the people who are being transitioned have really intensive needs, and without a good backup plan or a monitoring plan, they're at risk if it's not done correctly. This recommendation would adopt a new eligibility category for waivers in the state of California, and there's an option that states adopt that allows people who have income less than 300% of the federal SSI benefit to be eligible for home and community-based services. You have to also apply that eligibility option in a nursing home because waivers are supposed to substitute for nursing home care, and if somebody is not eligible in a nursing home, then they're not eligible in the community. And the reason this is an important one, and it addresses institutional bias, is because of what I mentioned earlier about somebody being able to spend down through the medically needy program and become medical eligible in a nursing home. But in the community, it's harder to incur the spend down amount, and it's harder for them to pay the cost of the cost share while they're incurring obligations to meet that spend down. Federal regulations only require that a person incur the obligations, but if you're the provider, you want to be more than having a person you're serving incur the obligation. They want to get paid too. Once the eligibility option is selected, then the state would determine how much of that income would a person keep to maintain their home and their other community expenses. So it's called the maintenance allowance or share of cost. The maintenance allowance identifies how much the person would keep, and anything above that would go towards the share of cost. Now, some states say they can keep it all, up to 300%, and some states say they can keep something less than the full amount. One of the other recommendations is geared toward helping individuals who are in a nursing home for a medium term to keep the home so they'll have a home to go back to. And this, California allows people to keep $209 a month of their income, which we believe is not sufficient to maintain an apartment or meet their monthly expenses. In order to receive this maintenance allowance, you have to be expected to return home within 180 days, and it has to be certified by a physician. But we identified states that have a little higher maintenance allowance, and one state authorizes or allows up to 100% of the federal poverty level to be retained by the nursing home resident to maintain their home. You could do it as a percentage of the SSI SSP payment, or you could just allow the person to keep their total SSI SSP payment and in order to maintain the property. There's another opportunity for maintaining the home, and that's for the first 90 days. The state can allow a person who's an SSI beneficiary to retain their SSI status, so they keep their full amount rather than convert within 30 days to the personal needs allowance. And this might be a way of helping people who are going to be in for short term to maintain their home. One of the recommendations is for expanding services in residential settings, and this residential settings provide an opportunity for people who don't have access to services at nights and weekends, don't have family caregivers or others, friends and neighbors that might be able to help them when the paid service provider is not around. Sometimes it's good for people who need oversight and supervision. And the assisted living waiver is a good start to begin to provide services in those settings. Other options might be to allow IHSS payments to be made for people who are living in RCFEs. We also think that over time the waiver could be expanded statewide, or assisted living could be offered as a service in the MSSP and the other waivers. I think what some states have done, like California, to gain familiarity and to phase in the program is they create a separate waiver for assisted living services. And this does allow them to get some experience with setting the rate and managing the rate and understanding how many people might apply for this service. But over time, it doesn't make sense, once you've gained enough experience, to know how to predict and project what the expenditures and participation rates might be. It doesn't make a lot of sense to maintain it as a separate standalone waiver because of the administrative hassle of managing 2 or 3 or 4 more waivers and referring people and terminating people from one waiver, say MSSP, because they became more frail and they wanted to go into an assisted living facility or an RCFE. So phasing out the assisted living standalone waiver and adding it as a service to broader waivers would make some sense. This is another option to expedite financial eligibilities. In some states, they allow case managers to say, well, based on your SSI statement and other information, we can safely presume that you're going to be Medicaid eligible. We will enroll you in the waiver with the requirement and the expectation that you will apply for Medicaid. You'll complete the financial eligibility, the financial application within a certain period of time, say 60 days or 30 days, and we will initiate services in the interim. Another way to expedite eligibility is not to presume it, but to have a case aide or a care manager or a social worker actually help the participant or the applicant complete the financial application. They get all of the information that the person is going to need to present to the eligibility staff. They get the documentation in place. They help them fill out the application, and they so-called fast-track the process. And I mentioned the co-location. My favorite story about co-location and being responsible in Washington, there's one agency that has all of the long-term care responsibilities, including for all populations. And at one point, the financial eligibility was often another agency, and the director of the long-term care agency said, I'm watching people go into nursing homes because they don't get their eligibility tracked processed quickly enough. And his good friend, who was responsible for the financial eligibility, said, well, if they're in a nursing home, I know they have a roof over their head and they have meals and they're safe. I've got a mother with screaming kids applying for food stamps and financial assistance, and they're sitting in the office disrupting everybody, so they're getting priority over your person that's ending up in a nursing home. So the person, the aging director, the long-term care director, said, well, why don't you reassign some positions and let me handle it, and then it'll be out of your jurisdiction. You won't have to even worry about it. And they did it, and it works terrifically. Now, that's something you can do when one agency is available to handle and manage and authorize all of the long-term care services, and there's enough of a willingness to collaborate between agencies to have one agency give up the eligibility function to another agency. I don't know how well that might work in California, given who determines financial eligibility, but that's another story. The final recommendation, and there's only one, and it's a heavy lift, and it's sort of like the case mix reimbursement. It's been recommended before. It makes a lot of sense. You've recently gone through state reorganization with the Department of Health and whatnot, so we know this might not gain any traction, but some of the possible components might be IHSS, MSSP, the assisted living waiver, some of the other waivers, adult day health, and then some of the licensing functions, both for nursing home as well as RCFEs. And that's the extent of our recommendations. This was a fun project. It was great working with Les and with Carol and Megan. And we're sorry it's coming to an end, but we're also greatly relieved that it's coming to an end. And we're happy to entertain any comments or questions that you might have. Laura?
On the slide that you showed services in residential settings, and I realize that residential settings span a gamut of definitions from state to state. But in California, if a facility is licensed as a residential care facility, it's supposed to have staff that are there and available 24 hours a day. So the recommendation to allow options for people who may have unscheduled needs and oversight and supervision. I'm maybe in a HUD setting, I can certainly see that, but in terms of a licensed residential care facility, my understanding is that there should be something there.
Yes, I probably wasn't clear. That's why those settings are useful and necessary, or a useful resource for people who need access to unscheduled services and oversight and supervision, because it's available there in those settings, and it's not in a person's own home oftentimes.
Okay, just since we're being televised, that's okay. If you have a question or a comment, why don't you come up to the microphone so that everybody who's watching at home or elsewhere in the building can hear the question.
There's no waiting list for this.
Thanks. Hi. First, I want to thank you. I'm Debbie Toth, and I work for Rehabilitation Services of Northern California. We have adult day health care, multipurpose senior services program. We've just become a lead agency with the what was Money Follows the Person program, CCT, and I'm overwhelmed right now with all of your findings. I think it's absolutely amazing. It's my first time in 7.5 years working in this field to sit in a room and hear adult day health care, multipurpose senior services program, long-term care continuum, one single point entry, all of these things, and it's in a state building, and it's very exciting. However, I'm just curious, being new to this arena, what impact your findings have policy-wise. So is this a tool that I get to use when I go and speak to my legislators and they can't get anything passed in California because the system is so corrupt? I mean, how do we use this as a tool to make those changes, I guess, is my question, and I hope you have experience with this so you can answer that. I certainly don't, so thank you.
Well, I think this report could be used by many different people at different levels. It can be used by state policymakers who have a vision and a commitment to long-term care and just need kind of a roadmap or a sketch as to how to proceed. It's not a detailed roadmap. It's more like a direction. It's more directional. It can be used by providers who want to see changes made. It can be used by other stakeholders to bring to their legislatures to say, and nobody's going to read this whole thing. And when you present complicated issues to policymakers and state officials, you have a short time to present it, and you need a really concise statement that you can leave with them to show what you're asking them to do and why and how it might be done. So I think the value of this report is it is kind of a historical document. It traces where California came from and where it is up at least until 2008, the end of 2008. And the information in it can be used by anybody who has an interest and a commitment to long-term care, and how you use it depends on who you're talking to and what you're asking them to do.
You sort of hinted at or commented on the big problem that I've got with your report, and that was that this report's useful maybe through 2007. Maybe 2008. There have been such dramatic changes in the landscape, and the recommendations of this administration would have been, if implemented, to virtually gut all of the home and community-based services that you talk about. And we're experiencing a serious deterioration in those programs and services that still remain. And my question is, isn't it appropriate that perhaps not you, but someone refocus your findings or analyze your findings or create an update or something to reflect the world in which we exist today rather than the world in which we existed maybe in the spring of 2008?
Yeah, you raise a point that causes me much anguish. And I think I think the best response I can give at this point is that first the project was funded under a grant that has limited resources, or has finite resources, so I doubt that there's time or opportunity to do an update. I think, however, what the recommendation that I think is pertinent today as it will be next year or was last year would be to look at where you are, develop a framework, say, here's where we are, here's where we'd like to go, here's our vision for long-term care across programs and departments, and here's what we think we can do and how we're going to do it. And if programs are being gutted and some are being saved because of commitment of legislative or agency heads or the governor, and some are being sustained marginally, that's where you are, that's where you begin, and things may get worse in the next 6 months or a year. But I think that one of the things that might help accomplish is to look not at program by program and spending by program, but as a system. I mentioned sometimes budget staff saying we need to take this surplus here to offset a deficit here. Well, you can't do that, because you can't do that in all of long-term care, because if you change one thing, it's going to affect others, and you need to have a perspective of the whole picture in order to understand how a change in one program might offset a change in another or create a change in another program that is not what you wanted to see occur. So I think the vision, the mission, the intent and philosophy, and the strategic plan would be a relevant place to start. And to the extent that as you develop that strategic plan, some of what's in here fits, terrific.
Jackie McGrath with the Alzheimer's Association. I want to thank you both for this excellent report and the effort, and all my colleagues who were involved. This is extremely well done and thoughtful, and has particular relevance for us and the families we represent, because California has just embarked on the development of an Alzheimer's disease plan, because we know that this is going to double in California by 2030. So we are going to be putting a major effort in looking at the financing component of our recommendations, so this will be useful. I have two questions. One on your slide with respect to reducing payment for vacant nursing home beds. Did you identify a cost now that California is paying by virtue of the fact that we do not have any such factor in our nursing home rate? And then my second question has to do with respect to the scope of the programs you looked at, only looking at waivers. We're extremely concerned about the adult day health care program, which fill a really critical and unique niche in this home and community-based services for Medi-Cal eligibles. And there's been some dialogue going on now for several years in this state about maintaining them as a state plan versus converting them to a waiver, and there are obviously a lot of cons to converting them to a waiver after they've operated so successfully for 30 years as a plan. I was wondering if in your analysis you drew any conclusions at all about whether in the long run they would be better to be a waiver so that they could become part of some revisiting of better management of the community-based Medi-Cal services. Thanks.
You want to take the first one?
It was hard to get hold of data on the adult day health care program. The databases that they have aren't really readily retrievable to get average statistics, or in fact we talk about the databases in the discussion of the adult day health care program, but it's hard to study it as a program because of the lack of access of researchers to the raw data of people. You can get data on an individual person if you know the case record number or the name. You can haul the record up, but you can't search and do statistical analyses across all records. And so it's a program about which we were not able to get really good data. One of our recommendations is the need to develop a common database for long-term care programs. If you can't get all of your, it may be an impossible haul events since the Little Hoover Commission recommendation to establish a single department kind of show that it's really a heavy lift to get a single department, and indeed a lot of folks are just happy the way things are and don't want to change. But it does seem to me in lieu of that you can get the functional equivalent or some of the benefits of having that single department by developing a single database that does allow you to compare and contrast and study folks, their medical costs, their outcomes, the acuities they have, the cognition they have, their mental status, and if you had that, then it would be easier to answer those kinds of questions of where those set of services could be placed in a system that would get you the most cost-effective bang for them.
I think there are two other options the state has explored. One is the 1959 State Plan Service. The other would be including it in a waiver. In terms of continuing the service, the same number of in order to maintain the eligibility the way it is, you probably would want to continue it as a state plan service. The problem has been that CMS is trying to eliminate state plan services that aren't specifically listed in Title 19, and adult day health care is not listed as a state plan service. States have been very creative to cover it as a rehab component, or one state just listed it as other service. If CMS, and there was a change last January in the administration, so there may be less pressure now to remove it as a state plan service than there was in the past. I don't know. If you had to move it to some other funding source, you'd have to determine how many people would not meet the level of care criteria and what other options might be available to those folks. If it were a 1915 amendment, then you can set the eligibility criteria at the same. But I know when we spoke with the folks that were responsible for the program, they were walking through both scenarios and didn't find a perfect answer. So it's a difficult question.
It originally began in California as an 1115 demonstration waiver, and those are kind of time limited. So it has been a waiver in its past.
She also asked about the paying for empty beds. How much money might...
Oh, no. You can make those calculations. We didn't in the report. You make the calculations by looking at how many Medicaid days you pay it at the different with the different occupancy, the change in per diem that you would pay times the number of days. So you can calculate those savings, and you can calculate them at any given occupancy. In the report, we use an 88%, but you could calculate the savings at 90% or 85%. I mean, we didn't do it, but it is doable. It's a fairly straightforward savings calculation.
Straightforward to him. I couldn't do it.
Hi, my name is Deb Roth. I'm with SEIU, United Long-Term Care Workers Union, and I have a question about workforce development issues. I'm wondering if you could speak to that in particular, because it is going to be difficult to find the workforce to be able to take care of all of the people who are going to need care. And as my colleague, Mr. Passmore, spoke about earlier, in this state we have what has seemed like an effort to quash a lot of efforts at increases in home and community-based services. And I noted that the slide on the nursing home labor-driven operating allocation, which I don't really want to get into a discussion of nursing homes here, but you made an interesting statement about it being a policy issue and then offered alternatives, but it was something that was in there to help increase staffing and to help make better wages. So how can you address these important issues, particularly with respect to home and community-based services? Thank you.
We haven't actually talked about in the paper in this report. Bob and I have had the opportunity in the last few years to study worker registries. There's substantial work being done in Michigan, Oregon, Washington, also Massachusetts. And so one workforce development concept that I think both Oregon and Washington are examples of these, where they have authorities or commissions that really act as a
as a way of matching, as a way of both educating workers and clients, as a way of matching workers and clients through registries, whereby folks who need services say they need them, and people who are looking to provide services sign up to provide services. So there are these those concepts, which I think are good ones, and which have been received the blessing and benefit of substantial SEIU backing in these states to help make them happen. So that's one organizational innovation that seems to have a very positive impact on workforce development. The AB 1629 system does reimburse the wages of staff. I mean, so in the cost, the wages of staff are reimbursed. So I don't. But in general, throughout all of healthcare, there is the constant struggle and it spans IHSS, it spans hospital help as well, of just the struggle to find wages in a competitive work environment, to pay wages that are high enough and the packages that are high enough to attract workers. We see that as just a common problem throughout all of healthcare. There are some steps you can take in some areas, like the workforce registry programs around personal care and home health, that are not done but would be a decided benefit.
Hi, I'm Deborah Doctor from Disability Rights California. And first, thank you for putting up with me and as a member of the committee and being open to at least consider the 35 pages of questions we submitted.
You were prolific.
That's probably the best thing anybody's called me lately, at least. We were. One point and one question. I was glad that you brought up the issue of the home upkeep allowance, and I wanted to make sure that people in the room understood how important this could be if it were adequate, where, you know, study after study says that the biggest barrier getting people out of nursing homes is lack of housing. And the whole home upkeep allowance allows somebody to keep their housing so you don't run into that problem. And in addition to being laughably low in California, the state also has imposed a higher standard of proof. The feds just say a doctor has to be willing to say the person may be going home. California decided at some point to insist that the doctor has to sign a paper saying the person will be going home. And understandably, very few people know about this program and use it. So we've been pushing now for over 2 years to have the administration just bring the regulation in line with the federal requirement to make it easier to use. And my question is, what would it take to, goes to the provider fee, what would it take to add personal assistance services to the list of services for which the feds allow a provider fee to be imposed and used? Do you know any history on that?
You know, I'm not offhand, I can't think of any state that has a provider fee on personal care assistance, but the range of provider groups is quite broad. I mean, it spans pharmacies, it spans home health agencies in some states. I don't know if it gets down to the level of individual providers, but theoretically, I don't see any reason why you couldn't. I mean, there's no limit there's no restriction in the Code of Federal Regulations that says, you know, you can't. I mean, that they're a provider class that wouldn't be capable of having a fee made to them. They're Medicaid enrolled providers. I mean, they meet that test.
Right. I was under the impression that there were 7 groups of providers that were allowed to have a fee. The nearest thing would be home health, which is not the same as personal assistance. Have you ever heard of a state being able to do this?
No, I haven't.
Okay.
I once did 3-4 years ago, I did a survey of all of the states and what classes that they worked on. And I'll go back and take a look at that survey and let you know if I see anything in the groups that they're doing, see if there are any previous examples.
Okay.
Again, see, I did last year, I worked the Inspector General's office in Health and Human Service. I worked General Accounting Office, and I worked CMS, trying to identify what states had provider fee programs and get any statistics on them I could. And nobody keeps any statistics, so you don't even know the amounts of provider fees that states generate. You don't know what groups they apply them to. There's simply no national statistics on this stuff.
Somebody would have to call, hello, state, what are you, starting with A and go?
Yes, absolutely. You have to dig it out state by state, and it changes every year. But, Deborah, I do want to just say one thing about the home maintenance fee. Bob made the point earlier that the best perspective you can take on long-term care is that these are all interrelated programs. And that you can't think of them as isolated programs like you simply have adult daycare. And the home maintenance fee is one of a dozen actions that you have to take simultaneously. And if you can take all those actions and twist all those valves, and those gauges, then you can actually see some perceptible changes in what's going on. And that's certainly an action that should be taken. And I can't remember the state, I once heard of one state that set it as just the cost of maintaining an average home. I mean, and not limited by FPL or SSI, but just set it at what it actually costs you to maintain your home. Yeah, you bet.
I'm Gary Passmore with the Congress of California Seniors, and I just wanted to suggest to help you make your search easier to respond to Deborah. The state of Missouri this past legislative session passed a bill, and it was signed by the governor, that would have allowed basically a financial intermediary to collect fees from individual home care workers and transfer that money to the state to create a provider fee drawdown or a quality assurance fee. They have been negotiating with their regional CMS folks, and they're having a lot of difficulty with them. Now, whether it's because of the particular language of their legislation, I don't know. But I've been pushing this idea to folks here for a couple of years. And just by coincidence, I used to live in Missouri, and I know the head of their Home Care Workers Association. And so I can pass that lead on to you, and they may know of other states because they may have tried to model their legislation based on what some other states were trying to do also.
Thank you.
Since he could go up twice, I figured I could too. Hi, sorry. I'm Debbie Toth still. So in listening to Jackie McGrath's comments and your responses about adult day health care and what a difficult time you had navigating finding any information on adult day health care, I wanted to point out that we as an adult day health care provider are not reimbursed even 2/3 what it costs to provide the service. So we're not like a nursing home where we get reimbursed what it costs to provide the service and then some. We're not in a position where we can gather that data, compile that data, and keep that data. As a matter of fact, many of us spend money out of our own pockets to pay for attorneys to keep our program alive in the state of California because it's constantly on the chopping block, which segues then into all of the legislation, all of the changing, all of the regulation that we have to do now. We've increased paperwork to the point where we're doing more paperwork than we are direct care. I just wondered, and maybe this is too micro, if your study looked into efficiencies in terms of these community-based service providers like adult day health care, like looking at waiver programs like MSSP where you have 70% paperwork and 30% care. I mean, things of this nature. Are those discovered or looked at in your paper? And also just the fact that you keep talking about putting more money into the Money Follows the Person program, but if there's no money put into the community-based services to provide the network of care for them when they're not in that institution, then there's no point in funneling money there. So I know you addressed the housing issue, but that's one piece of it. It is the biggest piece, but it's one piece. And I don't know if any of that was coherent.
Well, we didn't get to the detail that you described, and in terms of reinvesting savings, we didn't specify. I mean, we meant generically the savings would be reinvested in home and community-based services, including adult day health care. So exactly how that would work would have to be developed.
There are techniques for studying what you want to call business process redesign, where you actually go and you look at what all the paper that's passed from office to office, the extent of the duplications, where the hang-ups come in that. You'd have to do that kind of, you'd have to apply that kind of methodology. We certainly heard comments from different groups on the fact that they have to get multiple licenses, the conflicting paperwork requirements of the state. So we got an earful, especially in the public forums, from people on those topics. But in order to actually study them, you actually have to get down and do something like a business process redesign, where you're actually looking at what form is filled out and how many times and who it goes to, and then you can re-engineer that process to make it more efficient. It can be done. I mean, there are methodologies for doing it. I participated in a business process redesign this summer of the Texas Medicaid Transportation Program. It supplies 5 million rides a year. We went into their offices in Texas, and we interviewed all their departments. We looked at every piece of paper they made, all the forms, and how they moved them from office to office, did Visio diagrams of each process, and that's the kind of methodology you could apply, and it would help. It would be beneficial.
I'm Jack Haley. I work for the Senate Human Services Committee. And is there a page in the report, or could you give a sense of if California did adopt these overarching recommendations, starting with focusing on cost effect, your general recommendations, your budget flexibility, at all, where does it come out in terms of costs and savings in your estimation?
We left that question to you.
Well, we didn't try to make any analysis of the savings or costs of each recommendation. A lot of it depends on the way you implement particular recommendations. That's certainly true with things like provider fees. It's certainly true with things like low occupancy provisions. It's the devil's in the details.
And we didn't have the capacity or the resources to cost out each of the recommendations and the time available.
So, but the force of the recommendations, when taken as a whole, result in not necessarily budget, but result in do you have a sort of concluding
yes,
longer lives or
in general,
happier people?
In general, the recommendations would help the state serve people more effectively and lower the rate of growth in total spending. So there's a table in towards the back that tracks from Washington's spending, and they serve 3 people in the community for every person in a nursing home, and over time, the number of people in the nursing home has dropped by 5,000 from about 15,000 to about 10 or 11,000. It's below 11. And they've taken those savings and invested them in home and community-based services. And their caseload for HCBS participants is going like this. On the spending diagram, they tracked what would nursing home spending have been had it increased at its historical rate of growth of 3%, and it goes up like this. Then they track their actual nursing home and community spending, and the nursing home spending is flatter and the home and community-based spending is greater, but they're spending about the same as they would have spent for 15,000 people, but they're serving 47, 50,000 with the same amount of funds. So, and another way to look at it is if the cost per person for HCBS is lower, then you're going to, and you expand home and community-based service, and at a minimum, you don't increase the Medi-Cal nursing home census. Hopefully, it'll continue to drop as it has over the past 7 or 8 years slightly. So the growth curve without home and community-based services is a one plane. You expand home and community-based service, you lower the overall spending curve, which is what many states attempt to do when they look at developing a more comprehensive system, an integrated system.
Right. I just want to say one thing. Bob is absolutely right. The bottom line here is trying to get control over your long-term care spending. Yeah, rapidly growing older populations are bringing with them a host of long-term care problems. If you're between the age of 65 and 74, your chances of Alzheimer's are 2%. If you're between 75 and 84, your chances go up to 19%. After age 85, it's 42%. I mean, as you get increasing proportions of older people, you're going to have pressures on your long-term care budget, and you have to find a way of getting them under control. And the kinds of mechanisms that are being talked about here of finding ways of expanding home and community-based care, reducing institutional use, funding the increase out of the decreased, funding the increase in HCBS out of the decreased institutional use, and then feeding that back into further reducing the institutional. It's kind of it's a loop. You know, as you decrease one, you increase the other. You feed your savings back into the decrease on the institutional side, which helps you expand it further, which helps you decrease it further. And you have to put into place the administrative operations, the endless tweaks of policy, whatever organizational developments you need to make it happen. But there are small states like our kooky neighbors up north, like as next Oregonian, I can refer to us as kooks, Oregon and Washington, you know, and Lottie Land, but also large states like Pennsylvania are doing this now. I mean, where you have really a significant long-term care effort that in the Office of Long-Term Living that went through the consolidation of departments, that has put on a 7-year transition program, that is taking thousands of people out of nursing homes, that is working with AAAs throughout the state, that is working with Centers for Independent Living, as they call them in Pennsylvania, throughout the state. And once you have that kind of statewide organized initiative, then you are able to get some control over your long-term care budget.
I just want to try and follow up on the Washington example that you just gave and track your analysis a little bit. The trending that you just described being same amount of money essentially spent, but 30,000 or more people served in the community. In addition to that, I'm thinking that if you looked at that, you would probably find cost savings from other systems that aren't incorporated in your analysis, like emergency services. Is that right, or have you taken into account other system costs in your analysis?
That's a good observation. It's not reflected in what the State Department up there sent us. Any other comments or questions? Well, once again, we want to thank the state for inviting us to do this project, and particularly our project director, Carol Schwartzlander, and Megan Uring. And we thank you all for coming and hope that you found this useful.